to Dr. Balbir Singh. He is the most terrific interventional cardiologist and electrophysiologist in this part of the country and maybe in the entire country. He's presently the chairman of cardiology and electrophysiology at Max Group of Hospitals. And he's one of the best electrophysiologists of the country. So he's going to be talking about past, present, and future of LA appendage occlusion. This is a very important procedure which we do, and Dr. Balbir had a commitment just after this, so we couldn't have his talk in the atrial fibrillation session, so we have requested him to do his talk in this session.
Thank you, Dr. Khanna, for having invited me to this elegant meeting of yours. So, atrial appendage closure has come as a procedure because atrial fibrillation is associated with strokes, and anticoagulation is mandatory in most patients who have atrial fibrillation. So, stroke risk in atrial fibrillation is high, anticoagulations are mandatory. These two facts we know. However, not all patients can take oral anticoagulations. Anticoagulations could be contraindicated, which could be absolute or relative. The relative is that a person has high SHAD-SWASK and high Hesbret score, so the risk of bleeding is very high. One of the examples I can give you is a CKD or a CLD case where this risk is really high. One is who has recurrent strokes on anticoagulation. That means that he needs an additional therapy. Then non-compliance is a big factor. You know, most of the NOACs that we are using now need twice a day administration. And it's very common for many patients to forget one dose. And even if you miss one dose, these drugs are short acting, they put you at high risk for a stroke. Poor quality of anticoagulation control, particularly those who take warfarin, or do take them with underdosed of anticoagulation. For example, apixaban 2.5 BD is not the right dose, and many people are doing that. Interaction with other medications can happen with warfarin. And then there are some absolute contraindications. Somebody who's had a life-threatening bleed, such as many of our patients who have an appendage closure, had an intracranial bleed, hypersensitivity to these drugs, or pregnancy in the first and third trimester. So we understand that the LA appendage is the cause of clot formation in 90% of the patients. So 90% of the patients, the source of clot is the appendage in non-valvular atrial fibrillation, not true for rheumatic, but true for non-valvular atrial. So if we can close this appendage, we can occlude it so that it does not communicate with the LA. Whatever clot forms in this LA appendage stays there, does not communicate to LA, and does not go to the brain. So this is where a role of LA appendage occlusion devices come in, that they close this appendage. Now, if we look at the trials, this is something relatively new therapy. You can see that in this slide that there are so many trials, but most of them are recruiting or ongoing. So there's only one trial, which is Prague 17, which compares LA appendage closure using Amulet or Watchman to NOAC. Other trials have done it against warfarin. So everybody says warfarin is an outdated drug, so we need a better trial. So this is the only trial I can share with you, Prague 17, where LA appendage closure was compared against NOAC, which is the recent, and they looked at endpoints such as CV death and device-related complications. Then we come to the devices that are available. So we have the device which is from Boston, which is Watchman, and the Ampla's Amulet, which is from Abbott. These are the two devices available to us in India. My major experience has been with Amplaza, which I've done 40 cases now. Both have a good outcome data. Both have some very nice studies then backing up. Lariat is epicardial stitch is not available in India and has also facing some FDA issues. So this is a procedure which I'll share with you of a patient, or 86 years old gentleman, had recurrent bleeds on apixaban, GI bleeds with 2 admissions to the hospital with blood transfusion. This is the septal puncture, and this is an SL1 sheath. This was exchanged for an Amplats 14 French sheath. After the septal puncture, this whole procedure is TE guided. This is a 14 French Amplats sheath into the left atrium. Then we place this sheath towards the left atrial appendage. As you can see, the sheath is now in the left atrial appendage. We open one of the lobes of the device. So this device lobe is now opening. Once having done that, This lobe is opened. We pull back the sheath and now open the disc. So you see, this is the lobe, this is the disc. And this whole procedure is guided on 3D echo so that we are monitoring where the lobe and the disc are. So the cautions are that you could perforate the appendage. The cautions are that you could not be covering the L appendage properly with the disc, so that can lead to thrombus migration. That can lead to problems. So this is an injection to show that our device is now well in place, does not move. This patient is also a post-op CABG. And this is the final picture showing that the appendage is nicely occluded and you don't see anything. And over a period of time, this flow becomes practically zero. At the time of release, sometimes you see a small trickle, but over a period of time, it just closes. This is the most recent trial of LAOS-3 intervention, which was presented at ACC, which looked at surgical occlusion of the epicardial during surgery of these patients of atrial fibrillation. So they compared LA occlusion versus no occlusion. And the LA appendage closure was compared to nose occlusion, and in the non-occlusion groups, the patient were given anticoagulation. The follow-up was for 3.8 years. 4,800 patients were recruited. And this was the primary outcome at 3.8 years. Ischemic strokes were much lower in the appendage closed group versus no closed group. So this is a real data of most recent of suggesting that LA appendage occlusion is really effective in reducing ischemic strokes in patients. Now this group, no appendage, they had anticoagulation. This group did not even get anticoagulation, yet the p-value is so significant. So if this procedure is done well, like the surgeons concluded this LA appendage in 2021 study, outcome is likely to be good. Secondary endpoints, you can see even systemic embolism, death were almost similar, heart failure was similar. So conclusion of the study was surgical occlusion reduces ischemic stroke by 33%. Now let's look at the 5-year follow-up, which was again published, 4-year follow-up of Prague 17, again published this year. They compared LA appendage occlusion versus a NOAC. NOAC could be any of the 3 drugs which are recommended for use. So appendage closure versus NOAC, the cardiac death, you see over a period of time, there is a fall in cardiac death from this procedure. There was no change in the stroke rates or TIA. The bleeding, of course, over a period of time, much lower in the LA appendage closure group. And if you look at non-procedures, after the procedure bleeding is much lower, p-value significant. So you see that there is no difference in stroke, but a great reduction in bleeding because no NOACs are needed. So in conclusion, the Prague 17 LA appendage closure remains non-inferior to NOACs for preventing major complications. Furthermore, non-procedural bleeding was significantly reduced with LA appendage closure. So at present, we are doing appendage closures for patients who have had a bleed or who are very reluctant to take oral anticoagulants. So our purpose is that we reserve it for this group, but over a period of time, we don't know whether these LA appendage closure will become a procedure of choice in many patients with atrial fibrillation until we get some more studies. We can't say that. Thank you very much for your attention, and I hope I ended in time.
Thank you very much, Dr. Balbir. You have been so clear and lucid as always. If you're here, we can take the questions in the end, or we can take, if you're in a hurry, we can take 1 or 2 questions right now.
Yeah, please take it right now.
Okay. So one, what do you think is the future of LA appendage occlusion devices, especially in terms of the feasibility of doing it and the cost in India? Because what I believe is there are many patients, but the expertise is lacking, and also the penetration of this device use is less because of the cost.
Right. So there are multiple reasons why this is being underutilized. One is the technical challenges. But over a period of time, people who are doing interventions on mitral or in the LA would learn it very fast. So it's not so difficult to learn. That is the first thing. Second thing about the cost. Now, this is a one-time cost. Compare this to a long-time NOAC therapy. So it is cost benefit. If you look at 5 years of NOAC, the cost will be cheaper for a one-time LA appendage closure. Second, readmission for hospitalization for blood transfusions of for major bleeds is another cost-related factor with NOACs, which is much lower with early appendage closure. So in my opinion, if a cost-effective analysis is done over even 5 to 10 years, this will be much more cost-effective than taking NOACs for a long period of time. So that is for the cost. Third is this procedure has some complications, but as you say, over a period of time, good operators complications have been very low. In 40 patients, I had embolization of 2 where we could just snare it out and put it back again. We had no mortality, no patient went for surgery. So this is relatively safe procedures for sure.
And how do you compare this with the lariat device?
So lariat device is a epicardial procedure. It doesn't, it needs an epicardial puncture. So that also needs special training to do an epicardial procedures. But it has run into problems with the FDA not clearing it and giving a warning. So there have been some issues with the lariat also. So a lariat is not yet in India, but I think it'll face a lot of challenges.
Thank you very much. If there's any question, Dr. Patel and Dr. Gurcharan, Dr. Bedi, who is also a cardiac surgeon, if he was there. If there are none, thank you so much, Dr. Bedi, Dr. Balbir.